Hello, I'm Charlotte Kroll. I'm with the Missouri Rural Health Association, and I want to thank everyone for joining us today for our Rural Health Clinic building and provider updates. Today we have with us Jennifer Cooper and Nicole Thorell from Wintergreen to present for us. We are recording this video for later viewing. And if you have any questions, please put those in the chat and we will address those later in the session. So Nicole, I'll turn it over to you.
Thank you. We are excited to be here with you all today and share some content with you. And as Charlotte said, we will be available for questions at the end. So I'm Nicole Thorell. I am a former Chief Nursing Officer and Director of Risk and Quality over a critical access hospital and rural health clinics in central Nebraska. I also am a practicing family nurse practitioner and a senior consultant at Wintergreen. So excited to be here with you. And I'm going to let my colleague Jennifer introduce herself.
Hello, my name is Jennifer Cooper, and I am a revenue cycle consultant for Wintergreen. I also bring many years of revenue cycle experience, more so in the critical access and the rural healthcare environment as well.
And these are our objectives today. And we're going to jump right into it for you all.
So regardless of whether a facility is designated as a provider base or an independent RHC, the type of bill that is submitted to Medicare remains the same, which is your standard 711. This uniform billing approach ensures consistency in how RHC services are reported and reimbursed under the all-inclusive rate methodology. The designation of the RHC impacts certain operational and reimbursement details, such as the cost reporting or scope of services, but it does not alter the structure of the claim form or the required bill type. All RHCs also submit claims using the UB04 with the bill type 711 for standard final claims and apply the same billing standards, including the use of appropriate revenue codes, HCPCS codes, and the CG modifier to designate the qualifying encounter. Nicole, if you'll just go to the next slide, please. So RHC providers include physicians, nurse practitioners, physician assistants, certified nurse midwives, clinical psychologists, and clinical social workers who deliver face-to-face medically necessary services within the scope of the RHC practice. Covered services in the RHC setting are those that qualify as RHC encounters. These include evaluation and management visits, certain diagnostic tests, mental health services, and preventative services recognized by Medicare. While a qualifying visit list is often referenced as a tool to help identify services that typically constitute RHC eligible visits, CMS does not publish or maintain an official qualifying visit list. It is recommended that you always follow the national local coverage decisions of your MAC and reference the medical coverage database to determine if an RHC covered or RHC encounter meets the qualified visit list. So some common covered services in an RHC setting include chronic care management, transitional care management, behavioral health integration, all of which are designed to support patients with complex or chronic conditions through non-face-to-face care coordination activities. These services will be discussed more in detail further in the presentation. Another common service offered is virtual communication services. These services include brief communication technology-based services, remote evaluation of recorded video or images, and online digital evaluation services. In addition, in-person and telehealth behavioral health services and intensive outpatient programs are also covered services. There are certain services that are also not covered in an RHC setting. These services include hospital services, ambulance, durable medical equipment, group services, technical components of services provided, and non-behavioral related telehealth distance site services. Additionally, non-face-to-face encounters such as phone calls or refill requests that do not meet criteria for virtual communication codes. Services rendered by providers who are not recognized RHC practitioners, such as chiropractors or physical therapists, are also excluded. A non-covered service in an RHC setting typically means that it is not reimbursable under the RHC benefit or billing methodology, specifically not payable under the all-inclusive rate. However, this does not always mean the service is entirely unreimbursable. There are two important distinctions. Is it not covered under the RHC scope of services? These services cannot be billed under the RHC provider number or reimbursed through the air. However, they may still be reimbursable if billed separately by an appropriately enrolled provider or supplier. Or is it not covered by Medicare at all? Some services may be non-covered by Medicare entirely, regardless of the setting. These are not reimbursable under any billing arrangement and may become the patient's responsibility, assuming proper notice is provided. An example would be like a lab test performed by an RHC that's not paid under the air and must be billed separately to Medicare by Part B by the appropriate entity. So in essence, an RHC visit must be a face-to-face, medically necessary encounter between a patient and an RHC qualified provider, furnished in a qualifying setting, and meet Medicare's criteria for a billable encounter under the RHC benefit.
All right, so let's get into some of those regulatory updates. And quite a few of these we will cover in more detail. Those that we aren't, we're just going to quickly highlight on this slide. So some of the regulatory updates this year that I'm sure everybody has heard about is the elimination of the RHC productivity standard for your cost report ending in last year of December 31st, 2024. They've also updated and removed the required test for the RHC and removing that hemoglobin and the hematocrit and the occult blood from the required list. They have expanded your same-day billing flexibility. So if you are an RHC that provides dental services, you can now furnish a dental visit along with a medical visit in the same day. And they also have modified that intensive outpatient program to allow for reimbursement of 3 and 4 services per day. I'm sure you've also heard about the new billable RHC providers. So with the Consolidated Appropriations Act of 2023, it included allowing RHCs to bill for your marriage and family therapists and your mental health counselors. So what does this mean for an RHC? You can now bill for mental health practitioners who meet all your applicable statutory qualifications for a mental health counselor, but are licensed in your state under a different title. So many states call these individuals different titles. So in Nebraska, they are licensed independent mental health practitioners. Other states have different titles, but if they meet that statutory requirement, you can now enroll them as a Medicare provider and bill for them in your RHC. And be reimbursed under that all-inclusive rate. There's a couple caveats that go into this that I think it's important to mention and are great reminders that my good friend Kate Hill at the compliance team has shared. Now with the new addition of these practitioners, you really have to look at your policies and procedures since these are providers in your clinic. If they're furnishing services during the time your clinic is open, making sure since they're not a medical provider that you specify in your policies and procedures what they're capable of doing. So I thought that was a very great tidbit from Kate Hill to pass along. So Medicare telehealth policy has shifted dramatically for the entire healthcare industry in the response to the COVID-19 pandemic. extending your Medicare health telehealth flexibilities until December 31st, 2025. And we continue to watch that, as I'm sure there will be updates and changes, but already some permanent changes in place include your RHC serving as a distant site provider for your behavioral telehealth, Medicare patients being eligible to receive telehealth services for behavioral health care in their home, expansion of services to include previously discussed new billable providers. And I think this is a huge benefit to the population that rural health clinics serve. A lot of the times we see patients that, lack that transportation, and really having that behavioral health integration, being able to provide those services via telehealth is a great benefit to patients we serve. Also is the expansion of care management services. So historically, RHCs have only been able to bill that GO511 once per month, but starting last year, an RHC can bill that GO511 multiple times in a calendar month if all requirements are met and services are not double counted. We're going to go through some of these services. There are a few caveats to that that we will talk about. Of note, as it is quickly approaching, as of July 1st, 2025, CMS will retire that HCPCS code GO511, which we have used to bill these services, and you will now have codes specific to the care coordination service you're providing. And I have listed them here under the different care coordination services. And there's different time requirements, different specificities to bill these codes, but we'll no longer lump them into that GO511. So I think it's important to make sure that our electronic health records are updated to include these codes to make sure that they're able to bill correctly, and that we're also training our clinical staff on using these new codes. As we talk about later in our slides, ensuring that we have everybody educated really helps smooth processes flow and reduces billing and coding errors, and ultimately timely reimbursement for your facility. So the first service we want to talk about is chronic care management. It is for your Medicare members with 2 or more chronic conditions. A lot of your other payers are also starting to cover these services, so you will need to check in your contracts to see who covers chronic care management for their patients. But chronic care management, you can receive payment when providing at least 20 minutes of qualifying activities per month. Some examples of qualifying services are communication with patients and caregivers, providing education regarding care, reviewing medication compliance, ensuring follow-up visits are scheduled, loop closure for exam results, and coordination with specialists. CCM is really crucial in improving our patient outcomes, enhancing patient experiences, and really reducing healthcare costs for individuals with chronic conditions. We've seen a lot of the clinics we work with have great outcomes with implementing a chronic care management program. Specifically, when we had one provider in a clinic who was having trouble buying into the service, and we were able to show how many times a specific patient was calling in and needing assistance. The nurse was able to document how much time she was spending on this patient, and to show this provider that that would be reimbursable services that they were already doing really opened their eyes to it's stuff they're already doing that helps and benefits the patient. And with this additional coordination and care planning, they were able to reduce that patient's anxiety, decrease the amount of phone calls, and increase the patient's outcomes. Principal illness navigation is another one of those care coordination codes. It's intended to help patients with serious conditions navigate their healthcare treatment. There are 4 time-based codes for principal illness navigation to help patients and their caregivers to identify appropriate practitioner for care needs and support, especially when multiple specialists are involved in caring for the patient and delaying care may have detrimental effects. The service can be provided by trained ancillary personnel under the direction of the billing provider. With all of these care coordination services, the patient must agree to the services and provide consent with an initiating visit. Services cannot be provided in a facility setting. So if your patient is in a skilled nursing home, they would not apply to this care coordination code. Examples of conditions where principal illness navigation services would be reasonable and necessary include cancer, COPD, congestive heart failure, dementia, severe mental illness, really those conditions that take a lot of coordination to help that patient navigate the healthcare system. Remote patient monitoring is defined as the collection of patient physiological data that is used to develop and manage a treatment plan. And then remote therapeutic monitoring is defined as the use of the devices to monitor a patient's health response to treatments using non-physiological data. RPM and RTM are the two that cannot be billed together, even when multiple medical devices are provided to the patient. The services associated with all medical devices can be billed by only one practitioner only once per month per 30-day period, and only when at least 16 days of data has been collected. Practitioners may bill remote patient monitoring or remote therapeutic monitoring with any of the other care coordination codes, such as chronic care management, transitional care management, behavioral health integration, principal illness navigation, but they cannot be billed together. And then the last care coordination code that I want to touch on is really that community health integration. When we look at those social drivers of health, we know the influence they have on patient health outcomes, which are independent risk factors for poor health status and physical illness. During an initiating visit, the provider would assess and identify any social driver or health needs that limit the provider's ability to diagnose and treat the patient's medical condition. This is really important to ensure that we are documenting to get reimbursed for this code. The provider has to clearly state how that social driver of health will impact the patient's diagnoses. The work of the community health integration services will then be completed by a community health worker or other ancillary personnel, and these services could then be billed by the provider who initiated the services. CHI are time-based services that can be performed monthly if medically necessary. The initial code G0019 can be used for 60 minutes per month in activities to address social drivers of health. Some examples could be conducting a patient-centered assessment to understand the patient's life story, strengths, needs, goals, preferences, desired outcome, anything that's limiting them from receiving their care. Maybe it be the cost of medications, maybe it be insurance, maybe it be transportation. As long as the provider ties that back to how it will impact that patient's health outcome and clearly documents the correlation, then the community health integration can be billed and services can be provided to help meet that social driver of health. All right, I'm going to turn it back over to Jen.
Thank you, Nicole. So some other updates, the 2025 physician fee schedule came with, it added the payments for the hepatitis B vaccination as part of the Part B covered preventative vaccinations to mirror the way we currently get paid for Part B covered COVID, flu, and pneumonia vaccines via the 100% of the reasonable cost. Typically, this is through the annual cost report, and it's being done this way until July 1st, 2025. Effective July 1st, RHCs and federal qualified health centers can bill and be paid for Part B preventative vaccines and their administrations at the time of service via a 95% of the average wholesale price. And of course, we will do the additional payment reconciliations at the time of the cost report. Congress in December of 2024 and March 14, 2025 provided that temporary extension of reporting medical and mental health telehealth, the same as we did in 2024. until September 30th of 2025. Congress and CMS should pass additional permanent extensions in the new year prior to the deadline. And we talk about this kind of later on in the presentation as well. Starting July 1st, you can get paid at the time of service for preventative influenza, the pneumonia, COVID, and hepatitis B vaccines and their administrations. So we also have the preventative medicine counseling. So there's a few topics here that we want to make sure that we discuss. One is that this is not used in conjunction with an evaluation and management service for the same visit. This is not used for chronic disease management or diagnosed conditions. This can be used for counseling on immunizations, lifestyle changes, risk factor reduction, preventative interventions, or behavioral health topics. The only time that you would use these counseling codes is when it is the sole reason, or the sole reason of the visit is for counseling. It must be clearly justified, and it must be allowed by the payer. An example would be if the patient presents for vaccine counseling prior to college enrollment, or if they're interested in understanding more about the HPV vaccine, or they have no current symptoms or medical complaints. And we provided the CPT codes and their descriptions and their typical durations over to the right side of the screen as well. These codes are the 99401, 99402, 99403, and 99404. CMS has specifically said that in the case, a standalone counseling only means that the vaccine is discussed and not actually administered at the time of the visit. So here we've listed out the different codes used for billing the administration of vaccines. You'll see that CPT code 90460, the immunization administration through 18 years of age via any route with counseling by provider. First vaccine is primarily used for pediatric patients with provider counseling on the first component. CPT 90461, administration of each additional vaccine, would be used when each additional vaccination is administered and counseling is provided. CPT code 90471 would be utilized when a vaccination is administered without counseling. CPT code 90472 would be for your second and third administration without counseling. CPT code 90473 and 90474 is used when the vaccine is administered by oral and intranasal routes and no counseling is provided at the time of administration. So on this slide, we've actually given examples. So you'll see on the first one, the patient received DTaP with counseling. The patient was 4 years old. So in this particular case, we would bill the 90460, and then we would bill the 90461 times 2. The counseling was provided, 3 components billed separately. The second case is the same. The third case, you'll see that the flu vaccine was given to a 45-year-old patient without counseling. In this case, we would bill the 90471, simply because it was an adult vaccination with no counseling, and it was a single injectable vaccination. The flu miss, the last example, is of course without counseling. In this case, we would bill the 90473, no counseling, 1 nasal vaccine administered. In the next slide, we've also given you just a few more examples to where you can kind of reference and know when to use the appropriate code. And basically, we're wanting to highlight here the different codes that you're using with counseling and without counseling. So RHCs should establish clear internal protocols and staff training to reduce billing errors and maximize appropriate payment for immunization services. These include always including the vaccine product CPT code and include the appropriate administration code. Properly coding the administration fee alongside the vaccine product code, maintaining detailed records of vaccine lot numbers, and confirming eligibility criteria for certain vaccines are essential for compliance and reimbursement. You always want to use the diagnosis code Z23 and counter for immunizations on your claim form. You also want to always ensure a qualified provider sees the patient if billing an RHC encounter, and always track separately for your Medicare cost reporting purposes. So this slide reviews basic key information, including that the patient's coinsurance is based on 20% of your charges for each medically necessary CPT HCPCS code. Therefore, it is imperative to document, code, and bill for all services provided on a line-by-line basis. Patient coinsurance is not 20% of the error nor 20% of the Medicare fee-for-service rate, regardless of it if you're getting your error. Being independent versus provider-based also changes how you will bill for the technical components of Medicare-covered diagnostic tests via the split billing. Lab services are paid via the clinical lab fee schedule. And then, of course, anything that is pre or post-op procedures performed outside of your RHC. Starting July 1st, you can get paid at the time of service for preventative influenza, pneumonia, COVID, and hepatitis B vaccines and their administration. Prior to this change, we had delayed reimbursement, basically at the end of the year via the cost report for key vaccines and administrations, causing cash flow challenges and administrative burdens. These claims will initially pay 90% of the average wholesale price for the vaccine product itself. It is still expected that an annual reconciliation will be performed to make up the difference. Several vaccine administrations will be paid via a special payment rule in the following codes rather than traditional CPT vaccine admin codes. So for the flu, you're going to use the G0008. Pneumonia is going to be G0009. Hepatitis B will be G0010. And the COVID-19 will be 90480. Incident 2 services on a Medicare RHC patient requires that they have seen an authorized provider face-to-face. The Medicare Benefit Policy Manual chapter states that when services and supplies are furnished in Incident 2, an RHC visit, payment for these services are included in the RHC error rate. An encounter that includes only an Incident 2 service is not a standalone billable visit for an RHC. It is important to note that some non-Medicare payers may allow a non-authorized provider to see a patient by themselves and report a 99211 if an authorized provider is given direct supervision. In other words, immediately available in the office suite, and may not require a face-to-face service using the MD or the qualifying provider's billing MPI. That is not the case with CMS, though. This is only for non-Medicare payers. And here we're just kind of going over the 2025 special payment rates. The care management codes G0511 and G0512. Up until June 30th, they're paid at the traditional 20% of the average Medicare fee schedule. After that, the new rate for the G0511 will go down to $54.67. G0512 will go down to $139.41. They've also changed the originating site telehealth using code Q3014. It is now paid at a flat rate of $31. And then they've also made changes to the intensive outpatient services, which will allow for the 3 approved services at $269.19 per day, or 4 at $408.55. And then also until 9/30 of 2025, the distance site medical telehealth using G2025 is paid at the new rate of $96.87. This slide discusses the split billing of services, focusing on the technical and professional component of services. The professional component will be billed by the RHC on the UBO4. The technical component should be billed by whoever owns the equipment on the appropriate claim form to get reimbursed separately for the technical component. And we've given an example here on the slide that kind of goes over EKGs and when to bill that based upon the RHC setting and then the technical component of that. Telehealth services are usually pre-scheduled and can be audio only under certain circumstances, such as many mental health visits. Telehealth visits may not be pre-scheduled if a virtual communication service transitions to a full and immediate telehealth visit, in which case the virtual communication is not billed. Virtual communication services are usually patient initiated, where patients are reaching out to see if they need to come in for an immediate visit or can they be taken care of virtually as long as they are unrelated to a visit in the last 7 days and it does not result in an immediate appointment. Virtual check-in services via technology-based interactive services or remote assessment of recorded video and/or images not originating from a visit in the last 7 days. Here we've listed out the new telemedicine evaluation and management codes. Keep in mind that documentation needs to be in the note of whether it was an audio or video or audio only and how much time was spent. Also, time needs to be a total time, which cannot be a range as 20 to 30 minutes. Also, ensure that providers are documenting their location as well as the patient's location in addition to the total time of the face-to-face visit, and if done via audio only, and why the visit does not include the video.
Okay, so we've talked a lot today about regulatory and billing and coding updates, and we want to kind of close out with why it's important to not only keep ourselves updated, but making sure that our providers are also updated on this information. So, knowledge is power, and really sharing that knowledge is even more powerful. We really want to build and maintain a shared platform and knowledge across these targeted audiences to ensure organizational alignment, optimize revenue capture, and maximize quality reporting. A lot of the times, when you pull all these people together in the same room, we don't use the same language. And so creating that shared platform where we are discussing, care management is changing and we're now using these codes and these are the requirements for documentation. That information needs to be shared across everybody. So provider billing literacy is not something that's taught well throughout all of the different provider educations. Specifically, I went to a family nurse practitioner program and we got maybe a lecture on coding and billing. And so I think it's really important as rural health clinics to identify and know what level of knowledge your providers have and provide them with that additional support throughout their practice. So one great way to do that is to really build a clinical documentation improvement program and develop those communication and relationships between coding and providers. So whether that be, those ad hoc meetings where coding sending messages back to the provider and not just saying, hey, this wasn't documented or I can't find this in your note, of really educating and ensuring they understand the why. So going back to the telehealth, okay, here's the new requirements that for me to build this code for you that you dropped, I need to find X, Y, and Z in your documentation so that the provider is knowledgeable and includes that in their documentation going forward. Also, as an REC, I think it's important that providers understand what that rural health clinic designation is and what that reimbursement methodology looks like. Um, as we've said before, knowledge is power. So the more information we can provide those providers, the more they can help ensure that the clinic is successful.
On this slide, we discuss common documentation issues, which include providers not having knowledge of CPT and ICD-10 guidelines. This leads to incomplete or inaccurate documentation that can result in billing errors, claim denials, or missed revenue opportunities. A proper code selection requires clear, specific documentation that supports medical necessity and accurately reflects the services rendered, making provider education on coding fundamentals essential for compliance and reimbursement. Providers quite often do not know that the specific impact time has on code selection and when to use time-based codes versus medical decision-making guidelines. Another issue involves using outdated templates that are not tailored towards specific services, such as updated evaluation and management guidelines, IPPE, and annual wellness visits. Untimely closing of encounters and failure to establish medical necessity on each date of service are other common issues, both of which can result in billing errors, claim denials, and missed revenue opportunities.
So some other provider best practices that I think it's important to share and ensure that providers are aware of really goes around that HCC coding and your risk assessment adjustments that are being made. So one that I was taught, and I didn't know this until recently in working with our revenue cycle individuals, is not to use history of to describe an active condition or one requiring treatment. So they might not be being seen for their hypertension at this time, but they don't have a history of it. It's not resolved, it's not gone away. They still have hypertension. So instead of saying, patient has past medical history of, a provider could say medical conditions include hypertension, hyperlipidemia, etc. In family practice, it's really important that we consider each encounter as a standalone encounter. I think in some of your other areas that providers work, such as the ER, this is easier because you're not building off, you don't have that patient relationship, but ensuring that every encounter, every time that patient comes in is a standalone encounter, and we are documenting all of the appropriate information and not building off of their last visit and leaving information off. Using the assessment and plan format that clearly aligns each diagnosis to the treatment plan. So a lot of your electronic health records do this very well. They'll have the diagnosis listed, and then below the provider is documenting their assessment and plan for that diagnosis. But if your electronic health record doesn't have it set up, really making sure that those diagnoses and treatment plans are separated. So we know that the metformin is being prescribed for the diabetes versus having all your diagnoses listed out and an insurance company not knowing what diagnoses goes which with treatment plan. Which really also goes into that next one is documenting how each chronic condition is monitored, assessed, evaluated, or treated, and its impact on your chief complaint. Using linkage language that really links that their condition that you're seeing them to could result in something else. So, maybe they're being seen for nephropathy due to their uncontrolled diabetes or resulting in. So that way that linkage is there in that documentation. We kind of talked about that, the ensuring your documentation is unique to each encounter. So not using that copy and paste format. We see that a lot where providers are copy and bring stuff forward, but making sure if that copy and paste function is able to be utilized in your rural health clinic, that providers are actually reviewing that and updating it and making sure that it's specific to that visit. Also ensuring that we are specific, that we are saying what's acute, what's chronic, what caused this, where is the location, what is the amount, as detailed as possible in the documentation. And I think this is an area that providers are very good at generally, in describing a wound or a laceration. Being specific is generally an area of importance to them. And making sure that we're acknowledging any pertinent laboratory or radiology results, not just that the system is putting them in the note, but that we are acknowledging their hemoglobin A1C is 12.0, which is resulting in their nephropathy, and we're starting the patient on X, Y, or Z. I think a big one also when we look at hierarchical coding is really documenting your status conditions at least twice a year. So these are for your long-term diagnoses. Your insurance companies, as silly as it may sound, we need to make sure that we are assessing the patient's amputations, their ostomies, their intellectual disability. While we as providers and clinical staff and clinic administrators know that an amputation isn't going to be grow back, and it sounds silly that we have to make sure we're documenting it twice a year. The insurance company requires that in their documentation for the HCC coding. Making sure that we don't say all systems are negative, really making sure that we list what we asked and what was assessed. If it's not specific, one can not say, yes, you listen to the lung sounds, you listen to the abdomen, you checked reflexes, really making sure that we're specific in, negative EENT, negative respiratory, negative cardiac, not just saying everything's negative. And then always making sure we review and update the problem list and the medication list. Recently, we've been working with some clinics and we found that the problem list wasn't being updated. And that's really your accurate diagnoses list of what that patient is being treated on. It really helps connect that documentation together. So ensuring that every visit we are looking at not just the medication list, but the problem list and ensuring it's updated. And now we will pause for any